and sir was gold medalist during his MD and DCH tenure. Sir has also done DNB. Post MBBS, sir has worked for almost 25 years as a consultant pediatrician and neonatologist. He has organized various state conferences in Goa. He was a faculty in various state and national conferences and CMEs. Sir is a IAP trainer for various IAP master programs such as problem solving of pediatric infectious diseases, IAP TOT, IAP Vaccicon 2012 TOT, Rational Antibiotic Practices TOT, and Management of Childhood TB latest guidelines RNTCP, IAP TOT. Sir has also chaired various sessions during the conferences, and he has attended various national and international conferences. Sir's field of interest is vaccinology, respiratory illness, and infectious disease. It is our honor to have you, sir. And I would, as we were discussing, influenza vaccination is on Zoom now, but there are many confusions regarding when to give. Because earlier we used to give only up to the age of 5 years, but nowadays many books have recommended various guidelines. So please clear out our doubts, sir, and provide us vision. Thank you, sir. Thank you so much. I request you to kindly proceed with your talk.
Thank you, Dr. Amar, for the very kind introduction. I must thank Kolhapur Academy of Pediatrics, President Dr. Sangeeta, Dr. Sunil, and the whole of Kolhapur Academy for giving this opportunity. And of course, I must thank the Sanofi team, headed by Dr. Pooja, and the rest of them, to Dr. Balchandra, for allowing me to this opportunity to interact with you. So I'll start sharing my screen. So as you, Dr. Amar has already said, yes, at the moment, it is the hot trending topic for us, because this is one vaccine that has come in our purview as such. But it's more important, not from the vaccine perspective, but to understand that what you are doing is doing rightly, correctly, and that's more important for us. And that's what is going to be the whole topic agenda today. First of all, I will cover just allow me to get a marker. Yeah. So I'll go through the peculiarities of influenza in children. Then we will look at the burden of influenza. Then I will look at this question, whether we should use 0.25 or we should use 0.5 all over uniformly. Then we'll look at the influenza seasonality and the vaccination timings, which is most in consideration at the moment. We'll look at a pediatrician's perspective on the adult influenza vaccination and the burning topic of today, that is influenza vaccination in the COVID-19 pandemic. So this is the agenda I plan to go through. So we all know that this has been an infection that we've been exposed to right from for a long time. And this has been a bug which has caused acute febrile. It's a highly contagious respiratory tract infection. And it's characterized with a very high onset of fever, myalgia, cough, cold, and often causes need of hospitalization. Rarely it can cause death also. As such, we know that this has been the primary cause of multiple pandemics. And as we all know, a respiratory bug is essential for causing a pandemic by the nature of the virus. And this has fitted the bill. And most of the pandemics in the past, major ones, right from the Spanish flu onwards, on which the current COVID-19 is modeled upon, is based on the previous pandemics of influenza. So this is something we have been exposed to in the past, so we know a lot. At the same time, if you look at the WHO statistics of 2000, you can see a WHO fact sheet. You can realize that despite so many years, this has become, after pandemics, just settled down into an endemic state. And you can see currently worldwide in 2018, approximately 3 to 5 million cases of severe illness were known, and out of which there were about 3 to 6.5 lakh of deaths all over the world. And importantly, in children, the annual attack rate is approximately 20 to 30%. That means of the susceptible children every year, 20 to 30% end up picking up this particular bug. Which means as we talk here, every 5 minutes that we spend talking, and maybe in the next 1 hour, you will find that almost about you would have lost approximately 30, 40 people. So this obviously is something that we need to take cognizance of. If such a disease has such a magnitude, it obviously results in huge economic burden, both at the microeconomic levels and the macro. Micro, obviously, we know that it will cost the parents drug cost, imaging, testing, doctor visits, hospital visits, and that results in indirect costs of loss of productivity, absenteeism, and a loss of life. Whereas on a macro level, as we can see happening with the COVID pandemic, the country loses on its GDP and also disruption of the healthcare system. But at the center of all this, we know very importantly that children are crucial in the spread of the disease. It's the nature of how the kids are. They tend to form and play in groups. They do not obviously follow COVID appropriate behavior, which means respiratory infection appropriate behavior. They are going to spend a lot of time with their grandparents, as you can see. They tend to want to go out and mix with a lot of people. So hence, it's very, very common for children to be predominant spreaders. And if you look at the flu burden in the school-going children, you can see that, as we've already said, the annual attack rates exceeds 30%, especially during outbreaks, otherwise maybe about 20, 25%. And it can go up to 30 to 40% during outbreaks. It is associated with an average 3-day period of fever, which translates into a 5-day of absenteeism from school. And it disrupts the parental workload also, causing a significant amount of disruption in their work hours. So the other important aspect, and this study from Polling et al., this was reported in New England Journal of Medicine. It's very interesting. In the US, they did a study, which was a retrospective study, and they looked at what was the reporting of influenza as mentioned on the discharge summary in laboratory influenza. And it is surprising that almost only 28% of people had a diagnosis mentioned and only 17% in the outpatient. As we all know, even if we hardly do the tests, but in case it is done, the patient is mentioned as pneumonia or a severe respiratory disorder or a bronchiolitis. They hardly mention influenza in the discharge summary. So there is something like underreporting. So whereas we look at the statistics, it's quite clear that whatever statistics we see is a lot more than what is actually reported. And even in an advanced country like the US, the same problem. And you can imagine in India, where we don't even do the tests on an average to look for, it's only when the H1N1 pandemic came by that we were more energized to do the test. Otherwise, it was always a clinical diagnosis. So this is important to understand what is the true global burden. And this came in the Lancet. It was by Harish Nair and group. And this is a data of 2011. You can see that over 90 million cases of influenza happened in children below 5. This is below 5, and this is the year 2008 before the H1N1 pandemic came by. And out of these, there were almost 20 million acute lower respiratory infection, of which 1 million were acute severe lower respiratory tract infection, translated to death of almost a significant number, a huge number, as you can see. More importantly, this particular study looked at the difference between the developing and the developed countries with regards to the influenza incidence below 3 years. And it was quite obvious that there's a huge discrepancy in that statistics. As you can see in the developing countries, it's a much higher as compared to the industrialized countries. More importantly, if you look at the mortality, you can see the huge difference between that in the developing countries vis-a-vis the industrialized country. And therefore, we see that out of these significant number, 99% have countries. So it also is important to note that the higher attack rates happens mainly in the preschool children and the school age children, where, as I've already said before, attack rates exceed 30 to 40%, especially during the pandemic. This is an important slide I would want to take you through. You can see that, as I said, the attack rates are high, which translates into a high amount of OPD visits, about 35%, which translates into a higher usage of antibiotics. But if you look at this bar diagram, what is important, you can see the major chunk end of disease burden is in the 6 to 12 months and going forward up till 5 years. But there is one segment which is often forgotten, and that is the one below 6 months. Now, this is the age group where we cannot vaccinate. We have vaccination from this group onwards. Below 6 months, what we can only offer is vaccinating the mother and doing a cocoon vaccine strategy, which I will talk to you later about. The other important aspect, if you look at the hospitalizations, you can see the majority of the load is up till 5 years. And this is why the IPCOI made a recommendation that we should vaccinate children up till 5. Beyond 5, it is not necessary. This is how the recommendations came about. So going forward, one other aspect to be looked at is what is the exposure to rough risk in children who are unvaccinated as compared to the adults. And there you can see very clearly that in the unvaccinated population, this is a sort of multiple studies from 70 to 39, so almost a period of 39 years. Different studies have been looked at the RCTs, and from this a correlative study can children have a much higher incidence of attack rates. And if you look at between A and B, you can see that it was 6 times higher for A and nearly 10 times higher for B. Now, obviously, this is because you were using a trivalent vaccine all this while along, and only one component of B was there. This is particularly addressed in the now quadrivalent vaccine. So what does that impact of vaccination in preschool? So we have seen that there's a high amount of a load, but if you vaccinate this group, then there's a significant reduction in influenza-related morbidity, reduction in influenza A, AOM, the URIs, the LRIs, and also that would result in direct and indirect benefit of vaccination in the form of big school days and so forth. So this is an interesting slide that I want to draw attention to. And as you are aware, around this time here in the 50s, late 50s, the Asian flu pandemic, or rather the epidemic, hit most of the Eastern Asian countries. And Japan had a significant amount of deaths because of that. A lot of children, adults succumbed to this disease. That prompted Japan to start a national immunization program of influenza. And you can see after this a steady decline. This refers to all-cause mortality. The all-cause mortality was referring to that gray bar. One on top, this particular bar refers to the pneumonia and influenza mortality. And you can see that even that came down over a period of time. But then what happened was, as happens in most of democratic countries, the parents objected. And in 1987, they said we have the right to refuse vaccination. And when that happened, you can see all-cause mortality went up, and so did the cause of pneumonias and influenza. It's very clear that not only vaccinating in a large number benefits the child, it also benefits the community at large also. That's very, very important take-home message. The other aspect of the influenza disease is because it leads to a significant amount of antibiotic prescription. Now, it would be absolutely true for all of us practicing clinicians. When we see a child with high-grade fever, cough and cold, we are very, very tempted to write an antibiotic. And this is obviously a trend all over the world. One factor that you can see is that you know that influenza results very often in secondary bacterial infections, in particular strep, Haemophilus, and the Staphylococcus group. This is basically a lot to do with microbial synergy. As you know, the concept when this influenza sort of facilitates these particular bugs. And you can see that excess usage of antibiotics at this time over a period of time when we know many of times it is not actually required. And you see that the AMR creeps up all the time. And as I said, it is not restricted to India. It's even in the US, where this particular study was done over 20 years, they found that there was a 10 to 30% excess in number of antibiotics used, especially in the influenza season. And if you can imagine in our country, it would be double of that for sure. That brings us next to the influenza vaccination in children. In particular, the next topic of debate is whether we should be using 0.25 or it should be in the sense that is this a suboptimal dose or not. So We all know that the ACVIP has endorsed the use of a uniform dosing schedule of inactivated vaccine, which is 15 micrograms per 0.5 ml for all children older than 6 months and up till the age of 5 years. So the question is, does this mean that the 0.25 ml, which is in the Sanofi brand, is it a suboptimal dose, or is it because of some other reasons that this recommendation is made? So if you look at, first of all, we have to understand what is the correlate of protection. The correlate of protection in this case for influenza for a long time has been standardized to a cutoff around 40 international units. And if you have a cutoff of 40 international units and above, that should give you adequate protection. Now, in this particular study, this is the immunogenicity study done by Agarkhetkar and group, and it is very clear to be seen whether you look at H1N1, H3N2, Victoria of B, and Yamagata B. For all strains, you can see a substantial increase from this, which is the pre-vaccination to the post-vaccination, with figures ranging from 800 to 1,500 in that range. Remember, 40 is the cutoff. So it's clear that this dose of even 0.25 ml is evoking a significant amount of immune response. And as you can see, this is the same thing what I talked about the slide. A good number of people have shown seroconversion, and this is the age group 6 to 34 months, at which point of time the dose was 0.25 ml. That was a study done. And therefore, that the dose of 0.25 ml in children in this age group induces significantly higher antibody titers to qualify to be highly immunogenic. So the point is 0.25 ml is not effective, not immunogenic. The problem, as the ACVIP addressed, was to do as uniformity, because there were other brands to be used, and all over the world they're moving towards to 0.5 ml. So yes, uniformity is important. It's also important not to have confusion in the refrigerators, usages, practicality. But that does not mean that a dose of 0.25 ml, if somebody of you chooses to use, is definitely still immunogenic. What is also important is to know what is in the product insert. And that is why the IAP position paper latest 2021 said that till the when you use manufacturer's age-specific recommendation and dosage should be followed till this final uniform dosage gets approved. As you all know, the DGCI protection from legal aspects we follow is they will always say what is the product insert guidelines. What is the product insert saying? So that's important to note, that if you use a particular brand where 0.25 ml is recommended, then you're well within your rights to do so. It is a immunogenic dose. But if you choose to use 0.5 ml, there is absolutely no problem. That is also safe, not a problem, and a marginal increase in the cost. So that would be my take on this particular section. I will take you to the next section that is very important with regards to understanding which when we should actually vaccinate our children. And that refers to the seasonal patterns. In the world, WHO has looked at different patterns, and therefore we have now got what is known as Northern Hemisphere, where the influenza activity peaks in the month of November to March, as you can see, and then it sort of fades down. And you have the Southern Hemisphere, where the influenza activity is very, very much like ours, April to September, then it comes down. Whereas in the tropics, where we actually are, we have a year-round activity, and we will have smaller peaks. What is an important point for me to draw your attention to is, if you look at the y-axis, you can see that our average is much, much higher on a year-round basis as compared to the Western world, especially the Northern and the Southern Hemisphere. We have got much higher overall activity, along with some peaks that we will see. Our peak incidence is obviously mirroring this, and therefore WHO has clearly told us that among the various zones we should be following is when to vaccinate, which formulation to use. For that, India has been put in the tropical Asia zone. And that is what you can see here, that we have got pink. It's very, very faint and not very clear on the slide, but you can see that we are in the Asian tropical zone. And therefore, you can see we have been recommended to be used. The Southern Hemisphere vaccine is ideal for India, and the vaccination timing for us would be pre-monsoon, so approximately April, May. Now, I'm sure all of you know that we have got 5 Sentinel centers all over the globe, which is based in different cities, which is given the task of collating data, which is once collected, is then given to the vaccine companies to produce a vaccine. Now, all this takes time. So for instance, if I want to look at a vaccine that I'm going to use in March or April of this year, then it is in September of last year when the vaccine companies got the vaccine to the seed to produce the vaccinations. But the data for that was collected 6 months prior to that by all the Sentinel centers. So effectively, it means that when I get a vaccine today to use, it is based on data collected nearly a year ago. And that's important for us to understand why, and as I go forward, I highlight this point, we have a very short window for vaccinating these children in the right vaccine, because the efficacy of this vaccine depends upon how right the combination is. And that is what we have to understand. The vaccination timing is, again, as I said, pre-monsoon in the month of April, and it is the Southern Hemisphere vaccine that we should be using. Ours is a big country, and if you look at this, again, it has been split into a section. The Jammu Kashmir, Tamil Nadu, and Kerala parts are put into the Northern Hemisphere category, because these have their peaks in the month of September, October. But for the rest of the country, we should be using the April, May pre-monsoon, the Southern Hemisphere vaccine. So why, as I said, why does appropriate timing matter? It's very important because, like I said, this particular vaccine has an effect not for very long, because the titers will start to wane over a period of time. It's more so for the type A as compared to type B. And on an average, it would last for about 6 months for type A, for maybe about 9 months for type B. This is an important point to remember. And therefore, it's important that we time this vaccination to the peak when the titers would be high, as to give maximum benefit to the child. So the current recommendations that we should remain focused on is, remember, please do not postpone vaccinations. Although, as I said, you should not be waiting. Okay, supposing it's the month of December, and I will say, no, I should wait for 4 months. No, in December, give whatever latest vaccine that you've got. You can subsequently move him over to the next schedule. So you may actually give it after 6 months. You should spend a lot of time in counseling the parents as to why you're doing it. At that very moment, if you explain, then they understand, and you can tell from next year onwards, every April, May, you should come to take the vaccine. Please remember, if you postpone vaccine, it could almost mean a missed vaccination. So this is something we should not lose an opportunity by. It is not that NH vaccine is going to be completely useless. There may be a slight difference, but that's good enough. Give whatever is available at that point of time. So give the flu shot to the child whenever he's eligible, because remember, we have a low-grade activity going on around the year. It is, like I said, significantly higher than what you see in the Western world. So that brings us to the next point. What do we do to children beyond 5 years? And as you said, as we know, the ACVIP has said till 5 years we should be giving it. Yes, the current recommendation is that beyond 5 years, we should give children of high risk. All these children should be given vaccine. But an exception can be made in this particular year, in this COVID-19 season, wherein we should not forget that this is a very, very close mimic of COVID. It will definitely add to the morbidity, mortality if you have a combined vaccine, combined disease, not vaccine, combined disease coming up in the population, not to also mention the amount of pressure that would result on all the healthcare facilities. So in this particular year, if you give beyond 5 years, it's perfectly legitimate. The other important strategy that I should want to talk to you about is what is known as cocoon immunization strategy. And you should remember that in pregnancy, we should always give cocoon strategy for influenza as we do and recommend it for the pertussis vaccine. Both this concept of the cocooning is because in the first 6 months, or in the case of pertussis for the first 1.5 months, the babies cannot be vaccinated. And therefore, the only strategy we have is to ensure that the mother gets a vaccine in the second or third trimester. And also all the other family members are protected so that for the baby gets protection. Mother will pass on some antibodies to the baby through the breast milk also and direct to the placenta also. That will benefit the child. So that is the cocoon immunization strategy which we talk about. And also we should consider giving the vaccine beyond pediatric age group, even to the adults who are coming in contact with high-risk children. If there are high-risk adults, then of course the children who are much older, they should also be given so as to protect particularly adults who are beyond 65, chronic kidney disease or chronic liver disease, COPD, diabetes, chronic heart disease. So for all such people, we want to protect them. You must protect the people around by giving them the vaccinations. You might vaccinate these people also, but also vaccinate the others. That will reduce the risk further. This is an important aspect. As you are all aware, with the COVID-19, we've all been involved in the care, not only of pediatrics, but also in adults. And that, as you all in practice must have known, when we give counseling to the parents, they trust a lot on us with regards to vaccination. And it's a fact that our physician colleagues are not comfortable when it comes to immunization dialogue. And they always refer the cases to us. And left for us, we should know our responsibility is to give the correct information out to society. And various organizations have made it clear that the burden of vaccine preventable diseases in adults is huge. If you look at this particular study from Nagvekar et al., and you can see here that in India, there was a case report of 39,000 cases of influenza in adults, causing nearly 2,270 deaths. This is from Mumbai. And WHO has said there's a 2 or 3 high-fold prevalence of influenza, diphtheria, tetanus in India. And you can see the high burden of diseases in. And why does that happen? It happens because over a period of time, the protection from childhood vaccine will weaken. They have immunity reduces in older patients. And there is a high rate of childhood infection in adults because of that particular reason. Plus, adults have got a lot of immunocompromising condition, adding to the various complications of the VPDs. And therefore, you must remember an unvaccinated adult can further on infect the young infant. So as I said in the cocooning strategy, more and more patients vaccinated is better for our pediatric population. When you see a child coming to and the grandmother is there, please do not forget to advise immunization to the grandmother, right from pneumococcal vaccine, which can only be Prevenar for the older patient. About the age of 50 years, you can only recommend Prevenar. You should recommend the influenza vaccine also. And there is now a recommendation for giving the herpes zoster vaccine also, but it's a very expensive vaccine. This particular study looked at what are the reasons why adult immunization is lagging behind, and multiple reasons were showed, but one of the most important factor is doctor hasn't told me about it. And this is where we need to step in because the physicians are now going to talk about it. We can bridge this gap by talking to them about the need for vaccination, and that's an important point and part in our tasks. So this is how, as even Walter Orenstein has said, pediatricians need to be called to do their part to help adult immunization. So what can we do regards this? Of course, we can display the adult vaccine schedule. We can print the vaccination schedule and show it to them. We can guide them to various centers. You know, what I often do is when a patient asks me, I always tell them, this particular vaccine is very important. Please take it with your physician or anywhere you want to take it. I do not tell them, please take it here, because I do not want to sound mercenary or avaricious, so that it's clear that I'm giving them only an advice. Very often they opt to take the vaccine with me, that's fine. I would suggest not to push the vaccine on them, but advise that they should take it. Also ensure that the staff is given appropriate vaccines. All our staffs are to be covered also. And ask the vaccination station, always the caregiver, which I just mentioned, encourage the pregnant mothers to receive the Tdap and the influenza vaccine. So all vaccines, with the exception of BCG, the oral polio, rotavirus, and Hib, almost all the vaccines are important for adults. Only the Hib is required in adults, those who are having problems like splenectomy or having issues where sickle cell and stuff. Otherwise, Hib is not so important for adults per se. But people who have taken a cochlear implant, for them also Hib is advised beyond 5 years also. So now that brings me to the last section with regards to influenza and COVID. Now, we know that there are numerous risk factors for both influenza and COVID. Both have got a similar presentation. There can often be a co-infection, particularly in the monsoon that is coming up with both the viruses prevalent. Fortunately, last year, there was not much cases, also because everybody was staying at home following COVID appropriate behavior. So masking and all was going on. But human beings cannot be trusted to follow rules all the time. Some point of time, they will slacken up and you will find again a resurgence of this particular virus. Plus, they have common complications following both these viruses. And therefore, if you see all these august bodies, WHO in its recommendation has said the highest priority for vaccinating is with health workers and older adults for sure. But the other priority groups are children and those with underlying health conditions and in pregnant women. And you also see the Indian Ministry of Health recommendation is that vaccination for seasonal influenza of healthcare workers and other high risk should be implemented aggressively. What is important is if you plan to vaccinate, there should be a minimum gap of 14 days between the COVID vaccine and the flu shot. This particular slide is important because if you see this particular report, and it was shown that this is actually a report from Mark Christopher Acura, that is basically from Pondicherry cardiology department, who said that they did a study and they said in this particular year that in countries or regions with low incidence of influenza vaccine, one single dose makes a big difference with regards to COVID severity. So their study was that if you give vaccination to the adult, benefit in reports from Brazil and other places too. But having said that, it's very important that this particular line is not by me, it's actually from Sanofi Pasteur, and this is important to give credence to them that they have put this line in broad red light that in the absence of RCT data, strong and consistent observational evidence and or biological mechanisms, we should not assume that influenza vaccine will protect us from the COVID-19 risk or severity. We should not communicate that influenza vaccines are beneficial against COVID-19. That would be wrong because we do not have exact data. So there are these observational studies in the past which have suggested the link of protection, but there is no evidence to that effect. So with that, I will conclude my presentation and I will be happy to take questions. Thank you. Hello?
Everybody has the presentation was so
it's either everybody is very happy or everybody is one. It's all or none.
no, it's
No, I'm just kidding. So I would be happy. I think at the beginning, Dr. Amar had mentioned about some question with regards to, so I've already addressed a couple of those questions. And if there are more questions with regards to the scheduling.
So there is one question, sir. Vijay?
Yes, sir.
Yes, I can see that.
Vijay, direct vichara to me.
Sir, my question is, like many are not vaccines as well. So
Yes.
what other vaccine?
Problem in at all or three. With varicella vaccine cannot be given. If there's an 18-year-old who has, then we will not be able to know whether we can combine COVID at the same time or not because there's no recommendation. Otherwise, you can give influenza
Any vaccines, means live or
live or let's understand the mechanism. In a live vaccine, what happens is that when we give it, it will multiply in the body. It will take over all the lymph nodes at the germinal center. So once you give a live vaccine, it takes 4 to 6 weeks before the process of immune conversion takes place or quietening, after which you can give a second vaccine. So if you give a live vaccine, you must keep at least 4 to 6 weeks gap before you give a next vaccine. But if it's a killed vaccine, which goes only to a specific germinal center of a node, you can, after 2 weeks or 3 weeks, you can give an interrupted vaccine schedule. That is, give it on the same for 4 weeks. With killed vaccines, you need not keep that gap.
So general rule applies to the flu vaccine as well, because we are just confusing.
No. That's the same rule that applies.
All right. Okay. Thank you, sir. Thank you very much.
In case of defaulter who has single dose below,
if someone has crossed 8 years, so this 9-year-old anyways gets one dose. Is that children below age of 3 years or below 8 years rather, we have a prime boost concept. So we'll give one dose, 1 month later we'll boost it up. But children who have crossed 8 years do not need that, because they've already been exposed to multiple episodes of viral infections through those 8 years. So after 8 years, you need to give a single dose only. The question comes for a below 8-year-old, if they took at a one particular time just a single dose, defaulted on the second dose, comes next year, then we do not consider that as a complete vaccination. So therefore, the child will need to take. So to example, only one dose, forgot the second dose, came to me at the 3 years, having taken just 1 year in the previous, one dose the previous year, I would give this child 2 doses. So I hope I've answered that question.
Yeah. Yes. One more question from Dr. Manisha Patil, madam. Can we give flu shot in post-COVID child, or when can we vaccinate a child who has already suffered COVID-19?
So a child who has completely recovered from COVID, it's already mentioned by the Ministry of Health, 2 weeks after recovery, the child can be given a COVID vaccine. 2 weeks after recovery, not from the time of onset. So that is with regards to the influenza vaccine. Same rule applies for any other vaccine, with the exception of course, rabies and tetanus. For example, if somebody has a bite, I'm not going to wait for 2 weeks. So you give it immediately. All the vaccines can include the vaccine.
True for adults, sir?
True for adults.
The same, Raju, sir. Has answered.
Sir, I have 2 kids, sir, whom I vaccinated with flu shot. And after around 2 weeks, they... Hello?
Okay. Yes.
Means their parents also had... I had given the second shot since it was a primary vaccination. So now when can I give them a second shot?
So this is the first schedule, right? You have to first time they're taking the influenza shot.
First time they're taking.
So now you'll have to wait for 2 weeks after recovery and more than 1 month beyond the first dose. So ensure there's a 2 weeks gap and then go. So it may be a 6 weeks or a little longer, also perfectly okay. But once the child is recovered, wait for 2 weeks and then give the shot.
Okay.
Any more questions? Almost 40 participants.
Very nice. Very nice.
Yeah.
think sir has touched upon all things. I think it's more or less covered in all regards.
Most of the queries are clear regarding
Thank you,
schedule.
Dr. Pooja. I think so.
The COVID-related questions.
Okay.
Madam, continue, Karaki.
You want to speak? Tell Dr. Pooja to speak.
No.
Dr. Sangeeta was
President
speaking.
was talking.
Yeah.
Kumbhaskar Madam was talking.
Yeah, same thing. Most of the journals and many parents were asking about this COVID and flu, and sir has cleared many doubts. So I think we can give even press note on this also, because many wrong messages, little misleading information is going on in the society. So as a president, I'm just thanking sir that he has cleared very clearly many doubts. So thanks, sir. That's what I wanted to say.
Thank you.
So anybody has any other doubts? So it seems nobody has any doubts. On behalf of Kolhapur Academy of Pediatrics, I thank Dr. HARSHAD Kamat sir for such an excellent presentation on flu vaccine. I also thank Sanofi Pasteur for arranging such a nice webinar, which is a current hot topic, and for clearing all the doubts.